Assalamu alaikum. Thank you very much for the invitation to speak here. I'm really grateful to Professor Fazlur Rahman, Professor Jamaluddin, Professor Fazila Malik, and Professor M.J. Azam for the very, very gracious and exceptionally kind invitation. Thank you so much for having me. Over the next 10 or 12 minutes, my job is to talk about left main PCI in 2023 and where do we stand. And so I don't have any conflicts of interest related to this talk. I'm going to start with a case and take you through a hypothetical patient and sort of use the patient as a template to answer his questions about left main PCI as to how it should be done and what should be done. So this is a hypothetical gentleman, 71-year-old man with the usual risk factors who presents with stable angina despite medical therapy and then undergoes cardiac catheterization. And sure enough, on cardiac cath, he has left main disease, which you can all see. I don't think my pointer is, let me see if I can switch to a laser pointer. You can see that he has disease in the left main. Clearly, it is surgical disease, and we recommend surgery. Now, Mr. Lim is a very intelligent man, and he sort of asks me a bunch of questions. He wants to know, can I be treated medically? He wants to know, will I live longer or better with CABG? Who should do my procedure, and how should my procedure be done? And I'm going to use these questions of his as a template to sort of talk about where we stand regarding left main PCI in 2023. So in response to his question, can I be treated medically? A lot of patients ask that in Asia, particularly, and I know in Singapore they do, and I'm sure in Bangladesh also. And the question is left main a medically treatable disease in 2023? And the answer is probably no. Most of the data we have regarding medical therapy versus CABG in left main is old data. And all of these trials have been basically have suggested a significantly higher mortality with medical therapy versus CABG. Now, you have to keep in mind that these are older trials. This is older data. And all the subsequent trials, including the ischemia trial, excluded left main disease. So that was not part of the algorithm. And so the most recent guidelines basically will say that although the evidence to support revasc with CABG for left main is derived from the older trials, at the present time, there's no other new data to refute that. And so therefore, in 2023, medical therapy for left main disease is not a good option. And so I would answer to Mr. Lim that can I be treated medically for left main disease? The answer is probably not. So he's very intelligent. He then asked me the next question, which is, will I live longer with CABG? And so does CABG for left main reduce mortality? And if you look at data, for example, the syntax trial, the left main cohort, and when you look at the data in a granular fashion for mortality, all-cause death, which is pointed out over here, actually there is no difference in mortality when you look at left main disease and revascularization in this syntax trial cohort, in the left main cohort of the syntax trial. On the other hand, repeat revascularization was different. Now, keep in mind that this is different for the three-vessel disease cohort of the syntax trial, but for the left main cohort, actually with revasc, there was, or CABG versus PCI, there was no difference in mortality. And when you look at left main disease and you look at disease complexity, on the other hand, for the more complex disease, there was a difference between PCI and CABG in the sense that CABG was better for more complex disease involving the left main, but for low and intermediate syntax score, actually PCI and CABG was more or less the same. And when you look at the 10-year follow-up of the syntax trial, again, PCI versus CABG, and if you look at the left main cohort, not the three-vessel disease cohort up here, but for the left main cohort, no difference in survival between CABG versus PCI for left main disease. Three-vessel disease, different story. Survival was better with CABG. Now, of course, this is old data, and there are more contemporary trials on left main disease, PCI versus CABG, including Excel and Noble, which were presented relatively more recently. They use different endpoints, but more or less the same, except that, Excel had an MI endpoint, which was controversial, and we'll talk about that in a second, using less complex disease, more modern stents, and heavy use of IVUS. And at the end of the day, in the Excel 5-year follow-up, when you look at it, there was really no difference in the composite endpoint. And I just want to draw your attention to the mortality signal. And if you look at mortality in Noble and Excel, there was no statistically significant difference. It is like the Chinese Shaolin Chen and his group. Not everybody is a Shaolin Chen. The EBC main, which is more mainstream, which involves usual operators, but still very good operators. Provisional is okay. Provisional versus planned two stent has more or less the same outcome. And so what I would tell him is, but if you go through two stent strategy, if you need to go through two stents, the data would indicate, based on the randomized trial DK Crush 3, that DK Crush is better than Coulard. And so what I would tell the patient is that your procedure should be done by a good operator, who high volume operator. It could be provisional when feasible. If you use two stents, you should use a good two stent technique, preferably DK Crush, and imaging will have an impact on mortality. So you should ask for your operator to do IVUS guided left main PCI. So what do the guidelines say? And I'd like to draw your attention to the European and the US guidelines, both relatively recent. The European guidelines published in 2019, the American guidelines last year. The Europeans are actually quite gung-ho about this. And they basically, of course, CABG is class 1 for everything, any kind of left main with any complexity. But the Europeans will say that if you have low complex disease and left main, don't even bother talking to a surgeon. Class 1, go ahead and do PCI. If you have intermediate complexity, you can still do PCI. It is class 2A. Whereas if you have really complicated disease and left main, don't do PCI, refer for surgery. The American guidelines are a little bit more conservative. These are relatively recent. And what they say is that, again, bypass surgery is class 1 for all degrees of complexity. But if you have in less complex disease, it's a 2A. But if you have high complexity, they don't really say anything about it. But what they say is, it is better to refer to a surgeon. And this 2A represents an upgrade from the previous guidelines when it was a 2B. Now, the fact is that in the real world of trials, in the world of trials, patients are eligible for both PCI and CABG. But in the real world, the overlap is a lot less because there are a lot of other considerations that modulate the decision making. For example, a lot of patients who should get bypass surgery are either too old, too frail, too sick, and they need to be they're not good candidates for surgery and they need to be considered for PCI. And a lot of patients who could get PCI are also too frail, too sick, they have renal issues, and we may need to think about medical therapy. So a lot of other considerations may modulate the decision-making regarding PCI versus CABG. So if I was to conclude, ladies and gentlemen, PCI and CABG are treatment choices that patients and physicians have to consider for left main disease. Surgery is beyond a doubt a very robust treatment option for left main disease, especially when disease complexity is high. And we still refer a lot of our left main patients for surgery because we believe it is good treatment. However, recent data suggests that for less complex disease, PCI offers a reasonable option because the gap between surgery and PCI for left main disease has narrowed considerably. I see most people in the audience are very young. When I was a fellow, left main disease, you don't even look at it. You see left main disease, you call the surgeon and you don't even talk about it. All that has changed. The gap has been bridged. The mortality signal in Excel is unclear. The mortality with PCI and for left main disease is either the same or slightly high if you want to look at the Excel numbers. Of course, it was not statistically significant, but it is important to honestly put that to the patient that maybe your mortality might be a little bit higher with PCI at worst. But as I said, the numbers are at 5 years, you have an 80% chance of being alive if you get PCI. You have a 90% chance of being alive if you get CABG. That is the difference. So it's not a whole lot, let the patient decide. But you have to accept increased repeat revascularization as a definite price to pay if you treat left main disease with with PCI. And of course, optimal technique is essential. PCI is not routine. I mean, left main PCI is not routine PCI. You don't want to be doing it once a year. Please send it to somebody who does more. Do the patient that service and that justice. And of course, you want high volume operators, image guidance, lesion preparation, FFR guidance, support, and good antiplatelet therapy. And finally, the decision-making sometimes involves incorporating a lot of other considerations other than just the anatomy, patient comorbidities, frailty, patient wishes all come into play when you're making that decision. Ladies and gentlemen, thank you very much for your attention.